Hello, my name is Marcus Chavez and I'm with IFARA TV. Today we will be cablecasting segments of the press conferences that were held during the 22nd CROI, which is the annual conference on retroviruses and opportunistic infections, which took place in Seattle, Washington this year. This segment will be presented by Sarita Shah, who's with the Center for Disease Control and Prevention, as well as Emory University. Both are based in Atlanta, Georgia. Sarita talks about a study of XDR-TB, or extremely drug-resistant tuberculosis, to determine the underlying causes of XDR-TB in South Africa and formulate a strategy to control the epidemic. She concludes that most cases of XDR-TB are HIV co-infected and occur due to poor treatment of multi-drug-resistant tuberculosis, or MDR-TB, versus transmission in high HIV prevalence setting.
Thank you. Good afternoon. Thanks for your interest in our study. As you know, XDR-TB involves resistance to the most potent first-line and second-line drugs for treating TB. So this leaves very few treatment options for patients and results in dismal cure rates. South Africa has among the highest burden of drug-resistant TB worldwide, which is compounded by the country's large HIV epidemic. Over 70% of TB patients are HIV co-infected. So until we have better treatment for XDR-TB, and even when we have better treatment, prevention of XDR remains paramount to reduce morbidity and mortality from this disease. So in this study, we sought to determine the underlying causes of the XDR-TB epidemic in South Africa in order to better inform public health strategies for controlling this epidemic. Specifically, we determined the proportion of XDR-TB cases that occurred due to acquired resistance from poor treatment of MDR-TB versus those which occurred due to transmission. We enrolled 404 participants with confirmed XDR-TB from KwaZulu-Natal province, South Africa. This province harbors half of the burden of XDR-TB in South Africa and has approximately 1.6 million people living with HIV. 77% of our study participants were HIV co-infected, and nearly all were receiving antiretroviral therapy at the time of study enrollment. Using sensitive and multiple genotyping methods, we found that 89% of study participants had matching fingerprint or strain types with one other study participant at a minimum and likely developed their XDR-TB due to transmission. These matching isolates formed into 22 different clusters in total, with one large cluster that involved 198 study participants in a single large cluster. We also used whole genome sequencing methods to further differentiate this large cluster, and while we were able to discern 10 or so microclusters, the majority of patients remained as one large cluster. And so what our study showed is that XDR-TB remains prevalent and widespread in KwaZulu-Natal, South Africa. And in this high HIV prevalence setting, the majority of XDR-TB cases are occurring due to transmission of drug-resistant strains. Poor treatment of MDR-TB accounts for less than 20% of XDR-TB cases that are occurring. This study and other studies from South Africa have shown the overwhelming role of transmission in the XDR-TB epidemic and really highlights the need to focus our attention on prevention of transmission through TB infection control. Thank you.